Michelle, are you back?
I am here.
Right.
Yes.
And Mr. Wright, do you have everyone you need?
Yes, sir. We have everybody who's going to be here.
All right. So before we go back on the record, um, I'll have our attorney swear you each in, and just please say your names and identify each person who's speaking for Michelle, the court reporter. And then after he swears you in, you can take it away and provide your presentation. Sound good?
Sounds perfect. Do they do that individually or us as a group?
As a group, and then you can each say I do and say your name.
Very good.
All right. We will go back on the record, Michelle.
Okay, we are back on the record. The time is 12:16 p.m.
Great. We will resume our hearing from August 14th. Next, we have the budget presentation from Northwestern. And I see Mr. Wright and his team. Welcome. Thank you all for being here.
Thank you, sir. We appreciate being here.
Great. And I'll have Mr. Hengsler swear you in, and then you can provide your presentation for, we have about 45 minutes scheduled till 1 o'clock.
Yes, sir.
Good afternoon, Northwestern. I'm going to read the oath to be administered to witnesses. And after I read it, I'll just have you each go ahead and state your name and raise your right hand. So I'll just have you go person to person so we can get everything on the record okay. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
Mr. Casavan. John Casavan, you still on? All right, Steph.
Stephanie Bro, I do.
John Minadeo.
John Minadeo, I do.
Devin Batchelder.
Devin Batchelder, I do.
Peter Wright, I do. John Casavan, are you on the line? Oh, looks like we lost our board chair. I do expect that he'll jump back on at some point. And when he does, we'll pause and allow him to pledge that oath. That's okay
That
with
works.
you?
Yep, that works.
Very good.
I'll turn it to you. Thank you.
Excellent. Thank you. Thank you, Chair Foster, and many thanks to the members of the board. We know and certainly appreciate that you have a very difficult job, oftentimes a thankless job, and we appreciate your service to the state of Vermont. I want to also take this moment to offer our thanks and appreciation to the healthcare advocate for their support and partnership with the implementation of Act 119. While NMC used to have a very generous financial assistance policy, there was a lot of nuanced detail, and they were instrumental in helping us get that right. So we're very grateful, and I think that is deserving of a call out. This slide shows two pictures. The first in the top right is Emily Allen. Emily is the nurse manager of our ICU and step-down unit. She's working with what we call Aspire nurses through the partnership we have with the Vermont Talent Pipeline and the Vermont State University. Like many of our peers, in addition to providing care, NMC is an institution of learning, and we engage countless educational institutions across the state and Northeast to train LPNs, LNAs, RNs, radiology technicians, PTs, OTs, physicians assistants, nurse practitioners, and many more. The second is something really exciting. This is a picture of Katie Shattuck. She's a pediatric nurse practitioner who joined our team a couple of years ago. Katie and our clinic leadership team opened up a pediatric development clinic for children with autism. This is particularly important because it is a clinic like pretty much no other in the state of Vermont. There are precious few resources who are willing to do this work and address this work. And it is already full in less than a year. We're looking to expand, and we haven't spent a second advertising it. So this is just some of the great work that we're doing to meet the needs of Franklin and Grand Isle counties and benefits the state as a whole. We get referrals from all over to this clinic. I want to take an intro, so take the next slide, Steph. A second, again, to introduce our team. John Casavan is our board chair. Mr. Casavan is a multi-generational member of our community. His father was a physician at what was Curbs and St. Albans Hospital that merged together to become Northwestern Medical Center. And his mother was a nurse who also worked at Curbs. John has served on the NMC board for nearly 2 decades, and as vice president at NFP, he has an acute understanding of the insurance market and the needs and struggles of employers across the state. Stephanie Bro is our Chief Financial Officer. Ms. Bro has been with NMC for more than 18 years. She started in our accounting office and has worked her way to the position of Chief Financial Officer, where she has served for the last 3 years. John Minadeo. Dr. Minadeo grew up in the Northwest region as a graduate of the UVM Medical School. He came to NMC right out of his residency and worked in our emergency department for many years. Dr. Minadeo became interested in quality improvement and eventually took a position as the ED medical director before being promoted to the chief medical and quality officer, a position that he's held for about 3 years. Dr. Minadeo has faithfully served NMC for more than 25 years. Devin Batchelder. Devin is our decision support and budget manager. He grew up in Franklin County as well and has been a member of the NMC financial team, leading the budget process and presentation for the last 18 years. Devin won't be presenting today. However, he is sworn in to answer any technical questions that may come up along the way. So let me just take a quick pause. Hopefully, Mr. Cassavant has made his way back onto the program.
I am here, Peter.
Wonderful.
My apologies for a technical glitch. Thank you.
Oh, that's
Chair
just fine.
John, you have to pause, and we need to swear you in with the attorney.
Thank you.
This will be brief. All right, so please go ahead and raise your hand, and after I state the oath administered to witness, you can say I do. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
You are sworn in.
Thank you. So, Chair Foster and the board, thank you very much for having us here today. I look forward to a time we can meet in person. I think our decision making and discussion and decision making will be much better when we can do that collectively. I think we're at an inflection point in healthcare in Vermont. As Mr. Wright said, I do have long roots in our corner of the state. My dad practiced medicine in the 50s, 60s, and 70s. Unfortunately, left us pretty early. He was a general practitioner and my mom a nurse, and they had 9 kids. Most of us that reside, I guess we all reside in Vermont now. I think I have 3 siblings that are in the healthcare profession. My wife's an occupational therapist. So I think I have as much working knowledge of the system as most lay people. What we learned when we heard from Dr. Hammery, was that we do pretty good work. He confirmed the work that we were doing, particularly around quality and engagement with our community partners. And I think the fact that we're probably one of the highest quality, lowest cost hospitals in the state further confirms that. I think we need to understand Dr. Hammery's message to us, which was we have an issue around transportation, housing, long-term care, mental health, workforce. Very little of that is within our control. And I think you as regulators and the hospitals, the community hospitals, need to work together to make sure that we right this ship sooner rather than later. Dr. Minadeo will talk about quality and our journey on high reliability. Peter will talk about our work around culture and engagement. And Stephanie will talk about stewardship or sustainability, the 3 pillars to our strategic plan. As I said, I think a lot of what we're talking about in the system right now is beyond our control. And as healthcare providers, part of the provider network, and as regulators, we need to figure out how to work together better. And so I look forward to this presentation from our leadership team and hope you will find that we have listened to your direction and that we have taken that very seriously in how we've prepared our budget and are doing the work that you would expect us to do. Thank you.
Thank you, John. We're going to hand it over to Dr. Minadeo, who's going to start walking us through some quality insights.
Thank you. Thank you for the opportunity. We wanted to spend a little time on those pillars that you just saw on the strategic plan to say kind of where we've been, where we think we're going before we get into the budget request. So as John said, I'll start with the quality and safety pillar, hand it over to Peter, and he'll hand it over to Stephanie that will then lead into the budget, the actual budget request. So the quality and safety pillar. So starting in 2021, we really cemented the organization's philosophy that focusing on quality and safety is really going to be the path for us to achieve our mission, which is to provide exceptional care to our community, and that all of the recruitment, retention, and finances will be secondary benefits. So to this end, what we did is we dove hard into high reliability training for the entire organization. If you're familiar with this, you know that really the underpinning of that is really culture change, which takes time. But some of the tenets of culture change, of that culture, is providing a workplace where everyone is on the lookout for failure points. Everyone feels safe in raising a safety concern, regardless of their title. That we assume good intentions and we examine the process when something goes wrong. We really reflect on how errors do occur, and we try to standardize processes and communication in order to mitigate them before it reaches the patient. So since starting that, we have 100% of our employees and including our physicians take this course within 3 months of their hire. We've also, as it says there, launched a hospital-wide hand hygiene initiative, which we'll talk more about in a minute. And as mentioned, created our strategic plan. 2022, we launched our sepsis bundle compliance sort of initiative, and that will also get into more detail on a subsequent slide. Process improvement is a third key factor. So Dr. Chasin was the former head of the Joint Commission, published a paper several years ago and noted that their study of the highest performing hospitals, they had 3 things in common. One, they had a leadership from the board on down, leadership commitment to zero preventable harm. The second was that they had a safe culture, as I just sort of talked about, so that errors and near misses are voiced, recorded, and cataloged. And then in order for that to be meaningful, they had to have the third part of it, which is a robust process improvement team and focus. So you collect the data, and you need to then look at the system and the process and use what you found to try to change process so that someone else in that position can't make that mistake, so that they don't recur. So those are the 3 things. And what you see on here, daily Gemba rounds and organizational safety brief that happens every day are 2 of those tactics. A third one that's not on there is we publish a zero preventable harm report every month, which details the preventable harm reports that are followed by CMS. And in the last 30 days, did we have 0? And if we didn't, what are they? In addition, in 2022, we formed a patient family advisory council. This is a group of community members who have had either good or bad experiences or both in healthcare, but they have a commitment to help us improve. And so they form a sort of internal focus group to provide us feedback on policies, on process or design or signage, etc. And then in 2023, we formed a physician-led patient experience task force. And in that, we have either guest speakers or we watch TED Talks together, and we have discussions on softer skills, on the perception of the patient's definition of quality. How do they assess quality, and how do we make their experience better in our communications? We talk about how culture drives outcomes. And then we also talk about how physicians are leaders, whether they have a title of a director or not, and that they need to know that because they have a disproportionate influence on that culture that is so vital to our outcomes. And John spoke about the refreshed strategic plan, and I'll let Peter and talk about the engagement survey as well as the collaborative in his section. So we can go to the next slide, please.
All right,
Stephanie,
showing hand hygiene on my side, but not on yours, huh?
I don't see it on mine.
So much for no technology glitches.
Are you guys seeing the hand hygiene slide or the pillar slide? Or
No.
There we go.
There we go.
Now we have
Okay.
it.
Delay. Big delay. Sorry.
Okay. Chair Foster, can you guys see that?
We can, yes, thank you.
Okay, thanks. So as mentioned, this is our hand hygiene initiative. So we started in 2021. We used guidance and direction from the World Health Organization best practice. And you can see that we began with a compliance of about mid 60s, and that's 60% of the time of 60% of the appropriate hand hygiene opportunities and defined by the World Health Organization of the five moments. And so our compliance rate gradually increased, and that is gradually is the word, and goes up and down just like all process improvement, but you keep at it with teamwork and persistence. We slowly change the culture, which is really changing habits and establishing those kind of muscle memory. And this is a combined data from our staff and our medical staff. They're very engaged in this as well. And just to provide some context, there was a study in JAMA in 2021 that studied hand hygiene compliance rates at a major hospital system in Chicago. And they found that their baseline prior to COVID compliance rate matched the national average, which is between 50 and 60%, as they cited it. They found that it did go up with heightened awareness on the COVID units during the height of COVID to over 90%. But then once we were kind of more in the shadow of COVID, they checked it again and it dropped back down to 55%. So we're very proud of having sustained our high compliance rate well above the national average. And so we think this will affect patient care, obviously infection rates. And this goes back to an example of culture change and high reliability. Next slide, please. So here's another example of using data and applying persistent methodical process improvement to standardized processes. For background, sepsis is an overwhelming bacterial infection that has a high mortality rate. Timely diagnosis is challenging, but important, and interventions positively affect outcomes. And so there's been some standardized bundle compliance bundles that have been proven to be effective. These are occurring at 3-hour and 6-hour marks, where different labs, prescribed amount of fluids need to be delivered, antibiotics need to be delivered, other interventions have to happen. And so it's complex, but we've used a collective focus, standardized identification tools, standardized communication alerts, teamwork between doctors, nurses, and in the lab with communications, perseverance. You can see that we've again gone up and down, but overall we've increased our sepsis bundle compliance rate to at or above the national average in just the space of just 1 year. The next slide shows CMS penalties. CMS uses various levers to try to inspire hospitals to improve, and one of them is monetary takebacks. And this is an example of over the past 3 years of what we have had to pay back. And so the blue line represents a readmission penalty, and there's been slow and steady improvement there. And the yellow line represents hospital-acquired conditions. The next slide. So this These are just some resources that we take advantage of through the Vermont Program for Quality and Healthcare. Just shows a level of our engagement. The next slide is data that I think you've requested us to get from them about our outcomes. And so again, from the Vermont Program of Quality and Healthcare, illustrating that on these quality measures that we are performing at the national rate, which is depicted by the blue colored circles on the far right column. The top section are hospital-acquired infections. So similarly to hospital-acquired conditions, these are things that happen to patients while they're in the hospital that they didn't come in with or not a natural consequence of their disease process. And so one could get infections while they're in the hospital, different types. If there's a catheter associated in their bladder, for instance, would be a catheter-associated urinary infection. And then the middle section is some mortality rates for different conditions. And then the final section is a 30-day readmission rate. And so, yeah. So then finally, this is something you also asked us to do, is to go to this independent data group called SAGE. And once again, they're showing outcomes on readmissions and safety measures and mortality. The orange or yellow there shows that there's inadequate data to report out on that metric, but where the blue sections show that where there is sufficient data that we perform at the same as the national average. There would be red if they're depicted if we were performing below. And so performing at the national rate, we think that is an acceptable starting place, but that's, our sights and expectations are much higher than that. We know that healthcare is complex and the complexity is increasing by the day. And so the only way we can perform at the highest level, we think, is to focus on culture, communications, systems thinking, and unending process improvement. So like the tortoise who wins the race, we need to be focused, methodical, and above all, persistent. So thank you for listening. That concludes my summary of the quality pillar, and I'll hand it off to Peter to discuss the engagement pillar.
Thanks, Dr. Minadeo. So we covered that quality data because we're committed to providing the right care in the right place at the right time, every time. In addition to being the right thing to do, it is also known to reduce cost. The best way to do that is to have a highly engaged workforce. And our team, as you've probably heard from other organizations, we feel our team is really special. We're going through a lot of change. So in 2022, we worked with our vendor Press Ganey to conduct an engagement and culture of safety survey. We repeated that survey last January, and these are the summary results. As you can see, our summary score, 3.89 out of 5. I would say, well, that's okay. It's not great. It's not where we want to be, but it's a decent place for us to start. The dark green and light green are areas of high engagement and high engagement. The yellow is team member, that reflected as neutral. You can see that's a little less than a third. And the red area are employees that are disengaged. Now you might think, oh gosh, we're gonna really focus in on those disengaged employees. And really where we're focusing in is on the employees that are neutral. We feel that's our greatest opportunity to advance and get them into the engaged or highly engaged area. We know when they're engaged, they will stay. And when we know we have a consistent workforce, we can provide that consistent quality and become that high reliable organization. What's important in this is that the key indicators for engagement all increased across the board in a statistically significant way. The top statistic you have underneath the circle is increase of 0.27. That is the key areas. We did so well that that green arrow filled in means it was statistically significant. We did so well that Press Ganey actually called us and said, hey, we've never seen improvement like this from where you were to where you are. help us understand what you did so we can start to gather some of those best practices. Now, before we get excited about that big jump and where we are, I think it's important to put it into perspective. We're still in the 27th percentile when compared against the Press Ganey National Database, and the 36th percentile when compared against AHA Region 1, which is the Northeast. So, nothing necessarily to celebrate except for continued advancement. And we also know that if we increase in the same way in the next time, we will be over the 50th percentile. So we know that that is meaningful and we're well on our way. And something we're the most proud of is the idea of the 700 to 800 team members that we surveyed, 72% responded. So anybody who does surveys knows that that's an incredibly strong response rate. So we have an understanding that this is really, truly how our organization sits today. Next slide, please. This is a report on the key indicators and where our responses were. Again, you can see those solid green arrows to the right on the score and trending, which indicate a statistically significant increase. You can see our national and Region 1 rating. We tend to look more at Region 1 because it's a little more of our neighbors and the culture of the Northeast. And you can see in some of those areas we're at or slightly above the 50th percentile. All to say, all indicators going up, all going up in a meaningful way, and well on our way to a more engaged workforce, which we know leads to greater quality, which we know leads to reduced cost. So let's go. I think I'm going to hand it off to Stephanie, who's going to start to talk to you about cost in the budget.
Thank you, Peter, and good afternoon, everybody. I am going to try to speak and drive at the same time, so just holler if there's another big delay. Peter, maybe you can do that for me. I'm really going to cover two things today. So you heard Dr. Minadeo talk about where we're currently at with our quality pillar, and you just heard Peter talk about where we're currently at with our engagement pillar. I'm going to start by talking about where we are currently at with our stewardship pillar, and then I'm going to shift into talking about the budget request for 2025. So this graph in front of you, this shows 10 years worth of operating margins for Northwestern Medical Center. It's a pretty easy graph to read. It's not terribly pretty. Between us, Peter likes to refer to this as the slide of doom, but it's not doom, and we're going to talk about it. There is a lot of negative, but I really want to focus on the improvement that we have made in this past year. So NMC ended fiscal year 23 with a negative operating margin of almost 7%. Absolutely not sustainable, not where we can be or where we want to be. But in the current fiscal year, we're projecting an operating margin, while still negative, much, much improved, a small negative operating margin, somewhere around 1%. And the last point on the graph shows what we are budgeting for next year. So again, just like our quality pillar and just like our engagement pillar, we're not where we ultimately want to be, but we're making good progress. I think one of the things that NMC does really well is we're consistently and constantly looking for ways to reduce expenses or to tap into new funding that might be available to us, right? It's just part of our day-to-day work. And this is just some examples of that work. This is not a full list of everything that we have done in the current year. And I'm really only going to talk about a few of these, but there really are many. NMC applied for and received a one-time Medicare low volume payment for $1.5 million. So that was a big one for us. Medicare low volume payments are not automatic. It's really up to NMC to recognize that we meet all of the criteria and to complete the application process. It's actually a very time-consuming process, but we did that and we were successful. We applied for and received a 3-year nursing pathways grant. I think you've probably already heard at least one or other organization talk about this grant. We're really excited and really grateful that we got this grant, because whether we got it or not, we have to do the work and we have to make the investment in our nursing schools and all of those specialty tech positions as well. We're struggling with recruitment just like every hospital that's already come in front of you. So that was worth almost $200,000 in the current year. We made a couple of changes to our pharmacy formulary. So we identified a couple of medications that we were purchasing, and these were high dollar medications. And we worked with our physicians and with our teams to identify some substitutions that were much less expensive. But that only works, and we would only make that change if those substitutions showed the same or better clinical outcomes. So it really needed to be a partnership between the clinical teams and administration, looking at that evidence, looking at those studies, and we have been able to implement changes in the current fiscal year of almost $170,000. Peter is going to talk shortly about the New England Health Collaborative, but one of the very first initiatives of that group was this opportunity for NMC to share our chief people officer with another community hospital. So that hospital, their HR leader had left the organization and they were going to need to recruit, but they needed someone in the meantime. And so they reached out to us to see if we could help. And we were able to get part of the salaries and benefits for our employee paid for and count that as other revenue. And that organization was able to, get help at a much lower cost than going to an outside vendor or an outside organization and finding an interim. So it was really a win-win for both organizations. We have deferred wage increases for all team members for 90 days in the current fiscal year. We reduced the wage increase for our leaders, meaning if all of the staff got a 3% increase, leaders got 2%, so leaders got less. And we have held intentionally certain open FTEs because we just don't think it's the right time. We don't think it would be responsible right now to fill those. And so all of those things added together have saved us over $500,000. And then the last one I'll mention is the leaders of our clinical units for a 90-day period this year, they worked one open shift per week so that shift did not need to be worked by a traveler at a very high rate or somebody on overtime. Our leaders really stepped up and they embraced that initiative and they got that done. And that saved us more than $40,000 in the current year. All right, I'm going to shift now and talk about the budget request for 2025. So this is how NMC looks against the 3 established benchmarks for the budget. NMC is looking for a 6.8% growth in net patient revenue, and that improves access to care. NMC is asking for a 7% increase in its commercial rate or our prices, or I think you guys refer to that as our charges. And that allows us to maintain strong operational efficiency. And NMC is budgeting for a positive 1% operating margin. Looking first at the net patient revenue increase and the access to care. We heard loud and clear from our community members. We heard from all of you. We heard from others around the state that access to care needed to be improved. And we absolutely agree, right? Our data shows that patients are waiting too long to get an appointment to see their physicians. So we worked really hard to recruit providers, and we've had a lot of success. We've had success in almost all of our specialties, every area indicated in green. So there are only 2 areas where we have not been able to recruit, and we will continue to try. We won't stop until we're successful. We haven't been able to budget increases in those areas until that happens, but again, we're not giving up. So when we look at that recruitment and that improved access to care, this is an actual roster of all of the providers that have really recently joined NMC or they're going to be joining NMC. And over on the right-hand side, with the green arrows and the percentages, that's the corresponding increase in volume that we have been able to build into our budget as a result of these providers coming on board. So this will absolutely significantly reduce wait times for patients who are waiting 3 months or 6 months or even longer to get an appointment. So now I want to talk about the commercial rate increase request and NMC's operational efficiency. So this first graph is one that you're very familiar with. It's your graph, it's your information, and it shows cumulative expense growth for a 5-year period for all of the Vermont hospitals. And NMC is to the far left. We are the very lowest on this graph with the total right around 17%. This next slide, I know it looks just like a slide that we saw a couple minutes ago, but it's not a duplicate. This is a new list. So these are items, these are expense reductions that we have built into the 2025 budget. So this is where hospitals say they are taking on risk or helping with the concept of affordability. NMC is absolutely doing that with this list. And again, I'm not going to go through all of them, and this was not a full list, but I'm just going to go through a few of them. We are going to implement bedside medication verification in our operating rooms. And what that allows us to do is it allows us to maximize 340B pharmaceutical savings. I think a couple of hospitals in Vermont have already done this, and so we're reaching out to them to say, how did you do it? What did you learn? You know, what worked well, what didn't work well? But that's a big one at 1.2 million. We have been able to recruit a second pathologist to our organization. So we will go from 1 employed pathologist to 2. And that recruitment allows us to reduce the amount of pathology services that we need to purchase from an outside group. And we're able to save over $132,000 there. We have also pulled out almost $200,000 worth of advertising expenses in this budget. We had advertising expenses to let our community know about all of the new providers joining. So we're still going to do that. We're just going to have to do that in a different way. But we're committed to doing that. And then I'm going to turn it over to Peter, who's going to talk about the New England Collaborative Health Network and the expense reductions we have helped our community partners take advantage of.
Thank you, Stephanie. Last year in the budget hearing, you heard me talk about the Vermont Collaborative Network. That quickly expanded to the New England Collaborative Network, and we firmly believe that that will turn into the Northeast Collaborative Network really soon. Those initiatives you've heard from some of our peers during their budget hearings, and we will continue to do so. But what I want to highlight today is a statistic, Chair Foster, I shared with you and when we met not too long ago, for everyone else to hear, is that we are doing something very different. There are collaborative networks across the country. They all work in different ways. What we are pioneering is the idea of opening this up far beyond hospitals. So the initiative that we're the most proud of this year is we're going to take $1.4 million of cost out of healthcare in the next year, and you're never going to see that. You're never going to see it in our budget presentation. It'll never be reflected in our numbers because it doesn't benefit us. It benefits our strategic partners. So by allowing home health agencies, primary care partners, mental health agencies to come together with us to do group purchasing, to make capital purchase together and to come together to buy insurance benefits, we are reducing their out-of-pocket costs because we believe that our focus is not only on the hospital, but being a leader and a collaborator within the healthcare network across our community and across the state. So this is really exciting to us. It solidifies our partnerships in the community, and it does a great job to make sure that primary care, mental health, home health, and other key partners are able to stay viable, are able to minimize their rate increases to the insurance market, and really keep us strong moving into the future. So just something we want to highlight, something that you don't always see what happens outside of our budget, outside of our four walls, but things that like this that happen every day. So I'll turn it back to Stephanie.
All right, thanks, Peter. Another way we looked at operational efficiency was through the National Academy for State Health Policy. So again, this was a reference that you provided to us. And when we look at that data, NASHP shows hospital operating costs per adjusted discharge, and NMC shows up at $11,022, which is below the state median, and it's also below the national median. This slide, it shows an internal report that we use. This is an internal way that we look at.
You got it.
Yep.
It was delayed. Go ahead.
Okay, sorry. This is an internal report that we use to look at operational efficiency. We call these productivity reports, and every department leader gets one every 2 weeks. So after the end of every pay period, we send out productivity reports. And we are able to generate these reports using a system called Vantage. We have access to the Vantage system through our partnership with Ovation. And Ovation gets staffing and labor benchmarks from a national group called Premier. So the Premier benchmarks are loaded into the system. We then load in our actual volumes and our actual paid hours, and the report tells us whether we met the benchmark or not. If the score is less than 100, we have an opportunity to improve. If the score is over 100, then we actually beat the benchmark. We have the option to pick what benchmark to use, and the vast majority of our departments, we set them to the 75th percentile benchmark. There are some where we set it to the 50th, but most are set to the 75th. And this example in front of you, I know you can't read it, and that's okay. This is the progressive care unit. So for this particular pay period, they had a productivity score of an 89. So they may have had lighter volumes on the floor that pay period. Their 6-month average score is a 94, and their fiscal year-to-date score is a 96. We have the ability to roll all of the departments together and look at a cumulative score for the organization. So the last pay period, the most recent cumulative score for NMC was a 97. So a very strong score. Going back to some NASHP data, they also look at hospital expenses in this way. They break expenses down into major categories. So in this case, direct patient care labor is the line represented in red. And then you have some other expense categories like non-direct patient care labor in yellow, capital in green, etc. And I really want to just look at the last couple of years. This shows the growth in every category over time. But when we look at the last 2 data points on here, what we see is a very intentional increase to direct patient care labor, and all of the other expense categories are really flat or even, going down slightly. If we drill into that direct patient care labor as a percent of hospital expenses, NASHP will compare NMC to the other PPS hospitals in the state, and we have the highest percentage of direct patient care labor as a percent of hospital expense. Another way, we look at operational efficiency is to look at rate increase requests or approved rate increases. We went back to the inception of the Green Mountain Care Board and looked at the average annual increase for each hospital. And Northwestern Medical Center is the lowest at the top of that graph at 3.87. And there's a 45% difference between the lowest and the highest. I also, want to specifically mention that NMC has not negotiated reimbursement increases with commercial insurers above and beyond our approved rate increases. Also looking at prices, we would call this reimbursement on our side, but you have seen this information before. So this is from RAND 5.0. And this shows the standardized price for outpatient services. NMC shows up at the very bottom of this graph, and we're not really sure why we show up as Quorum Health Corporation. So we're going to get to the bottom of that, but that is NMC. So just to wrap things up for me, again, each of our pillars really is a multi-year journey. It's about progress. It's not about perfection. We have tried very hard not to look at just one single data point. We have showed you where we're currently at. Some of that data isn't perfect yet. Most of that data is not perfect yet, but we've also shown you where we want to go. We think if we look at expenses, if we look at prices, if we look at what we charge, if we look at history of rate increase requests, that this really tells a story of an organization that is strong operational efficiency and has been good stewards. We want to go from a small negative margin to a small positive margin, and ultimately we think a financially sustainable margin is somewhere around 3%. And I'm going to hand it back over to Peter.
Thank you, Stephanie. I appreciate that. This is a great picture. This is Team NMC at the first ever Pride Parade here in St. Albans. We're very involved with the community at every step as they continue to celebrate everything that's important about being in Vermont. You heard a quality message, you heard an engagement message, and you heard a financial stewardship message. All of which are things that you asked us to engage with. So we want you to know that you asked, we listened, and provided the data that you are asking for. NMC has provided credible and sufficient evidence that our budget improves access in an organization with strong organizational efficiency. What we are doing is hard work, and it reduces expenses, not just within our own organization, but with our strategic partners across the community. And as you know, community hospitals have an important role to play in providing, high quality, affordable care in Vermont, and NMC continues to be a leader in that space. I want to end this presentation by talking to you. We've often talked about affordability. We're going to talk to you about value. Now, I'm going to apologize in advance. I'm going to ask you to think about math, not actually do math, but think about how math is done. When I talk about value, I talk about a fraction. I want you to think of a fraction of quality over cost, which is to say the way to make value go up is either to improve quality or to lower cost, right? We know our basic numbers around fractions are you make the numerator go up or the denominator go down, and the value of that increases. We've clearly demonstrated whether it is price, what we charge, what we've asked for rate increase, how our expense growth has been over the years, that we are a leader in the state about responsible cost. And we continue to look for avenues, as Stephanie pointed out, to bring those costs down or to make sure that they grow at a slow and sustainable rate. We are at the very beginning of our quality journey, and as you can see by what Dr. Minadeo pointed out, we are already at the national median, the national average in many areas, and we really haven't kicked it into high gear yet. As we move through that cultural change, as we increase the engagement of our team members, we will slowly, methodically, and sustainably change the culture within our organization and increase quality. So as we continue to reduce cost, as we continue to increase quality, we will increase the value exponentially of the value of the healthcare services that we provide our community. So with that, Chair Foster, we want to say thank you for the opportunity to tell you about our story, to tell you about our continued journey. It's something we're incredibly proud of. It's something that we hope you look at and reflect and say, NMC is doing what we're asking them to do, and they are indeed a leader in what is arguably an incredibly difficult task of trying to make healthcare increasingly high value and increasingly accessible. So thank you, sir. That's the end of our presentation.
Thank you. We appreciate the remarks and for using the tools that we provided. It was very helpful. I'll open up to the other board members for their questions.
I can jump in. For the 10 years prior to joining the board, I worked a lot on helping organizations assess where they are on their HRO journey and to monitor their progress over time. So I recognize the language you're brings back a lot of fond memories. And I just want to commend you on your commitment to the journey you're on and the improvements that you've made and also maintained. I wonder if you have thoughts on how regulators could help facilitate the work that you're doing.
That's an excellent question. I'm gonna defer to Dr. Minadeo first as our Chief Medical and Quality Officer. Does he have any thoughts about that? And then Mr. Cassavant, Stephanie, and I can chime in after.
Thank you. I don't think I'm the right person to talk about the regulators. I don't really know.
Yeah.
I think when it comes to policy, as somebody who spends time in the policy space, understand that there is, while we know high quality care and highly reliable care results in a lower cost, it does require an investment and it does take time. And so regulators can help recognize the investment. I think regulators can call out where we're making investments to know how much we're spending to go down that journey, where we would like to spend more money. I will tell you, we're not spending all the money that we want to go down that journey. John's quality team, they'd love to have 2-3 more process improvement folks on their team. We have one. We made a commitment to have one person completely dedicated to nothing else but process improvement this year. I'd love to have 2 or 3 because I think that would accelerate the process. We simply couldn't afford to add that to the budget. As you can see, we've already struggled to stay within the parameters that you asked us to stay within. So that's certainly one area.
I think I appreciate the thoughtfulness, and it's a hard question. I've been thinking about it a lot as well, and I think the obvious easy answer is give us more money or allow us to have more money. But I think a more subtle answer, maybe a more useful one long term, is help point at places to look in your budget and in your organization, almost like the Swiss cheese model that you're all probably using about
Sure.
errors and harm. If we were another tool to help identify where to look, I think that would be useful.
Sure.
So,
certainly having statewide resources that help, and bringing us together and saying, hey, we want everyone to go on a high reliable journey. So we're going to help support that and standardize it. Here's a shoot at the moon. My peers will probably all hate me for saying it, but how would quality, how would high reliability, how would patient care improve if we all were on the same electronic medical record? Right. So part of what our struggle is every day is the communication between getting access to information, which is pretty good, right? But how much money do we spend in our own individual technology connection and even statewide connections that if we all said, hey, we're going to be on this electronic medical record and the database is going to be one database and it's going to live in a safe place where, no one's going to get inappropriate access to that data, but all the access that they need. How would that improve high reliability? How would that improve our quality journey? I think that's a great opportunity. When we look at where high reliability slips, and when we look at, I talked about the right care in the right place at the right time, we would have spent time on this, but we just didn't have it in the presentation today to talk about the number of people that are continued to be stuck in the wrong place, whether that is people suited for long-term care that are still stuck in our inpatient unit, whether that is mental health patients, I'm really excited about the pediatric unit that's coming online in Southwestern Vermont. We've often thought, hey, we have a pediatric unit, we have a lot of general adults. Wouldn't it be great if we had a geriatric unit? It's something that we've offered to talk about and commit to. So I think helping us open up more appropriate places for care where we tend to get distracted is when we're taking care of patients that shouldn't be in a hospital. That diverts our resources, that distracts our attention and takes time away from the things that we really need to do and the patients that we really need to care for. And quite frankly, is repeated areas of violence and creates disengagement with our staff.
I hear you. I appreciate the thoughtful response. I think I'm going to reflect on all of that in the spirit of identifying areas to look that I haven't heard about in your presentation. But after reviewing your budget, I've got a few questions. In your 24 budget, your total margin was budgeted at 2.8 and is now projected at 6.9. Could you say a little bit more about what happened there? What led to that variance in total margin?
Sure, I'll ask Stephanie to answer that question.
Yeah, it's been a good year in the stock market, right?
Okay. Yep.
That really is the answer. And I would love to. We do budget for interest and dividends, right? We do, but what we don't budget for is just any sort of unrealized gains or losses because we just have no idea. But that is the difference that you're seeing.
Yep. I want to turn for a moment to your profit and loss statement, and your budgeted free care has grown from 1.6 million in 2020 to 5.6 in 2025. That's one of the largest increases I've seen in reviewing budgets. Yet at the same time, your bad debt has grown from 10 million to 17, which is also among the highest in the state. Could you describe for me, please, your efforts to slow the growth of bad debt in your community?
Yeah, absolutely. So, I don't like our ratio. I don't want our ratio to be, what it is. We've done some really tangible things over the years. I was thinking about this and reflecting about it the other day. Not things you probably haven't heard before, but we placed financial counselors right at the front of the hospital to try to increase that free care or discounted care number. We years ago actually went to 400% of the federal poverty level in our policy. So we made some changes to Act 119, but that wasn't one of them. We were already there. We had all of our counselors at the front of the hospital become certified health assisters, right, to help people sign up for Medicaid or for some insurance product. So I've looked at okay, every year we really are trying something tangible. So I attribute all of those things to the increase that we're seeing in the financial assistance and free care line. But on the other side, I do need to shift some focus and attention on bad debt. So we're going to be doing that work. I know it's happening across the state, but we all still need to dig in and look at that. I just can't take that as an answer of it's happening to all of us, so it is what it is. We're really going to, maybe do some focus groups to try to understand, what is it? Should we have done something different up front when you were physically here from a collection standpoint? Do we need to offer something different on our bills or our statements? So a lot of work to do.
Okay.
Yeah, Mr. Walsh, I'm going to add something to that. It's probably going to be a little bit unpopular, but I think it needs to be said because it reflects the reality. We're relentless when it comes to aggressively saying, how can we help? Even before someone goes on charity care or financial assistance, we're like, hey, you're eligible for Medicaid. We have a group and a small army of people that really lean in hard and heavy to help people get access to the programs that they deserve access to. Where we struggle and where things often end up in that bad debt column is people don't want to play ball, right? We can't just assign something to the financial assistance program. They have to fill out forms. They have to create disclosures. And there are a cadre of people who just won't do it. And I will tell you, if Megan Smith, who's our director of patient financial services, were here, many of them use very colorful language about how and why they aren't going to do that. And so we work really hard to help people understand that we can't just assign it. We have to have these forms filled out. That is a requirement of us in order to measure need, right? And when it usually comes to those assets, people are really, really hesitant. And whether that's distrust or hiding or something else, I will not make a statement because I don't know. But what I know is we get a tremendous amount of resistance in that vein. And it's really hard because, look, it makes us look great. The more we get from one bucket into the other makes us look better. So we absolutely want to make that shift, as Stephanie said.
Yeah, I understand. And I think we hear that regularly when talking about this topic. And I wonder if this topic would be something that you might be able to bring to your learning collaborative to talk about, because I don't doubt for a moment everything that you just said. I think from a research standpoint, particularly information from ProPublica, a lot of the people who also aren't filling that out, it's because they're overwhelmed with the housing crisis, their transportation difficulties and food insecurity. And so they're certainly not hiding anything. They just can't find the time and the wherewithal. Their lives are in chaos at this moment. And so it's a tough problem.
It is.
And maybe the learning collaborative could help.
Yeah, I totally agree. And we're also open to anybody who has figured out how to do it. We're absolutely willing to learn from anybody on this. And maybe this is one of those initiatives that the state can help us with by doing some kind of study. We make no assertions about the why, and all the things you talked about. We've had recent conversations. We've been down to the one of the shelters where folks get housed and where they can get food. And we heard all of those stories, and we're working with those folks to figure out, hey, how can we help you here? What are the things that we can do?
Well, I'd like to switch to another measure. The Lown Institute has a fair share index. They build that index off of the 990s that you all submit. And they look at the dollar amount of community benefit provided in a year related to the tax exemptions received for an organization. And in 2023, according to that institute, your community benefit amounted to $4 million, which is quite high. The tax exemptions totaled about 7 million, meaning that you received $3 million more in tax breaks than you contributed to the community. That number seems large, but it places you in the middle of the pack in Vermont, right? And where there's a range from one hospital that is positive 8 million, meaning they're doing $8 million more of community benefit than they receive, to a low of negative 19 million. But in the spirit of helping direct you to this organization as a regulator, those are things that I'm interested in, and directing efforts in your high reliability journey to try to understand those numbers. That would be, I think, something to look at. The community needs assessment that you did in 2022, it's great. It's really, really well done. And the top needs are affordability, transportation, mental health, substance use concerns, food insecurity, and interesting, something we don't see in other hospitals, physical and emotional safety. There's a lot of people in your community who it sounds like they're scared. And so I want to try to, I'm trying to align that with the volume increases and the staffing increases that you're bringing in. And are those the two orthopedists, the cardiologist, the podiatrist, and the focus on increasing access? How do you see those aligning or not aligning with the community needs that you found in the needs assessment.
Sure. So clearly, the community had a great need, as you saw from the wait times and the lines and how long it took to get access. So the obvious answer to your question is we're bringing them in just to deal with what we know is the obvious backlog and painful waits that folks have to do when they don't decide to go somewhere else because they don't want to wait. And as you know, they can go somewhere else and they wait there as well. We focus a lot on our own internal psychological safety. So this is about, making sure that everybody feels comfortable raising their hand when they think that something isn't going right. You heard Dr. Minadeo talk about that in our high reliability journey. It's not something that we just say we're going to do. We talk about it. We talk about, and I use myself as often as I can, how it is not only acceptable but expected to challenge everybody in the organization for the sake of whether it's patient safety, family member safety, or our own team member safety, including challenging the CEO, which I'm very proud to say my staff is leaning into more and more with every day that I'm here. That's really important to us. We launched a new initiative about violence. As you know, violence in our emergency department, violence on our inpatient unit, violence even in our clinics is rising and creates safety issues, not only for our team members, but for our other patients who are here and have to hear and experience that. So we've created new signage, new policies. We have a zero tolerance for those things, and we're working more and more with the appropriate agencies, which aren't always law enforcement, I think is important to point out. We've just launched our next community needs assessment, so we're in the process of doing those surveys now. And we're really interested in the constituencies that don't engage with us or don't engage in healthcare at all because of safety issues. And most notably are the tribe in Missisquoi, the Abenaki, who are very hesitant to engage with any healthcare system based on Vermont's long and unfortunate practices of eugenics. They're in our backyard. We have made measured efforts to both culturally align, to understand and celebrate their culture, and to let them know that we appreciate that diversity and it's something that is we want to learn more about and that we are welcome to here. We also reach out to the chief and the leadership team to figure out how is it that we can rebuild that trust that will end up in better proactive healthcare in addition to reactive healthcare, which is really what we do at the hospital. So that's just a couple of examples. I could tell you about our incredibly strong DEIB program, the fact that we're gathering SOGI data at registration. I mean, all of those things that create different levels of psychological and physical fear that prevent patients from coming and getting care, that we are leaning into, not only on our own initiatives, but we're bringing those folks in and saying, help us design this properly. So Dr. Minadeo talked about our patient family engagement advisory council, and we bring those folks in, the different constituents, to say, how do we do this in registration? How do we create a meaningful environment here? What are the things that you need, like examples of food when you're an inpatient? And so there's just example after example that I could lay out exhaustively, but I won't. The last thing I would say is, I'd be remiss if I didn't point out why we are a nonprofit organization and why we don't pay income tax. We pay the highest amount of provider tax, 6%, which is $7.6 million in a tax. And unlike other states, we only get $1.3 million back, where in most states it's at least a level, if not an advancement, for their disproportionate share payment. So if you think about that delta of more than $6 million and the impact that would have on our budget in reducing commercial rate increases, those are other policy issues that lead to, the nonprofit status and some of the things that drive the cost of care.
But thank you. I really appreciate the thoughtful responses to my questions. I think one of the things that I'm trying to do, and with your new needs assessment coming out, when an organization requests more in their budget than we had put out in guidance, if I see that that overage, if you will, is going to meet community need or going to meet the deficit in community benefit. And there are priorities, objectives, key performance indicators that show that money is going toward these things. That becomes a much easier budget to approve. When it's hard to find alignment, then it's more of a struggle. So I say that hoping in the spirit of improvement and the journey you guys are all on. That so thanks again for the thoughtful replies. I really appreciate it, and like hearing about your progress each year.
Thank you, sir. We appreciate your attention to those details and hope that we've done some effort to assure you that that's where we're leaning in.
Great. Thank you so much. I think I'll jump in here next and thank you to the Northwest team for your presentation. Hopefully I have some just clarifying questions for you first to start us off. I just wanted to understand some of the assumptions around the charge increase, the 7%. If you could just break that down for me, how it's going to be distributed inpatient, outpatient, and professional, that'd be helpful.
So our budget request would be an across the board. It would be inpatient, outpatient, and professional services.
Okay, and can I just ask, with regard to the professional, I was trying to understand in the narrative, and let me just read this to you, this couple of sentences in here. The budget assumes a 0% change to outpatient physician professional fee reimbursement for all payers. However, to ensure compliance with the anticipated budget order language, gross charges for physician professional services will be increased in fiscal year 25 by the same rate as all hospital charges. Could you just help me? I didn't quite understand what you meant there.
Yeah, so last year we proposed 7.1% increase to hospital inpatient, a 7.1% increase to hospital outpatient, and a 0% increase to the professional fee. And so when you took the assumed volume for each of those three buckets, it came out to an overall rate increase request of 6%. And so the 6% is what went into the budget order. And that just creates a real challenge for us, because if I'm wrong about how much is going to land in the inpatient bucket or the outpatient bucket or the professional fee bucket, then it's not going to come out to be 6%. It might come out to be 6.1 or 6.2, right? Because budgets are built upon assumptions. Mm-hmm. So I think this year I'm having a similar challenge because, you know, if I say that I'm going to do an across the board rate increase of 7%, so that's why we went in that direction this year. But now we're saying, okay, but what are you really going to, if you increase your charges 7%, what are you really going to get paid in additional money from the commercial payers? And in our case, that's like 6.4%. But again, if I'm wrong about what the mix is between hospital services and professional services, then it's not going to come out to 6.4%. It's going to come out to something a little bit higher or a little bit lower. And if you try to apply that per commercial payer, right? We have 100 of them. We all know the big ones, but there's lots of very small commercial plans. Then I don't know how to do that. I don't know how to put something in the order that really truly is an estimate that's coming out on that rate decomposition worksheet. So it's an issue I know I've talked to Elena a lot about and her team, and happy to talk to you guys about more about that as well. But that's why we went for an across the board, but we're still having a challenge. And we've provided some recommended budget order language that we think would kind of work for both sides. But, you know, you guys would need to take a look at that.
Okay, I appreciate that. And I may follow up with Elena to better understand that language that you're proposing. What is the assumption that you're making about the rate increase for traditional Medicare?
I believe it's I'm going to ask Devin, 2.something%.
1.7% market basket, both inpatient and outpatient.
Okay. And what is the assumption that you're making about Medicare Advantage rate increase?
So Medicare Advantage plans, and again, Devin might want to chime in here and help me, but when we look at the data overall, there is a difference between what we ultimately get reimbursed from traditional Medicare versus Medicare Advantage. And I think it's about a 7%, lower or worse reimbursement rate from that group.
Yeah, and so for that group, we're assuming that from their starting point, they will also go up 1.7% because most of them are tied to Medicare, but not set at 100% of Medicare.
Okay. And then what is the assumption that you're making about the rate increase from Vermont Medicaid? 0. And then what is the assumption that you're making about New York Medicaid?
We have very, very little New York Medicaid, so I don't think we put in anything.
Okay, so you don't get very many New Yorkers coming over for care. Okay. Thank you. On the income statement, I'm trying to understand, I'm looking at the projected, sorry, phone ringing. The projected 24, the outpatient care revenue for 24 projected to the 25 budget. And it looks like about $46 million or, close to a 20% increase when you combine outpatient with outpatient physician. And I'm just wondering if you could talk a little bit about that breakdown. That's a significant bump up, 20% increase in outpatient revenue. And I have some suspicions about where it's coming from, but I'd like to better understand from your viewpoint, really how that breaks down, given that large increase.
Yeah, I think it's here at 18%. Is that what you're saying? I'm looking at our.
Well, I added the both two lines, right? So,
Okay.
I added the outpatient care revenue and then the outpatient care revenue physician, right? So if you add them both together from projected to budget, it's about 20%.
So really, it goes back to that slide where I showed the roster of all of the providers that are going to be joining, and then the corresponding, increases in volumes over off to the side. So not all of those providers are surgeons, but some of them are. And so they're all going to have professional fees, right? But some of them are going to have surgical volumes and surgical revenues as well. Some of them are going to have DI, procedures, lab procedures. So all of the ancillary revenues that they would generate, and they're really hitting that outpatient line and that physician line. So it goes back to that big influx of providers, all of the recruitment we've done to really try to improve access.
Okay, so that's about 5. Is that about 5 MDs that are contributing almost $50 million? Is that about right?
I think it's more than 5. I would have to go back and look.
Okay. All right. So maybe we can talk a little bit about the access. I hear from you all, and I see some of the numbers about the painful waits and the access backlog. And I see the areas where you are increasing FTEs, pathology and cardiology, as you described in the presentation and also in the submission. And it seems to me that the solution to the access problems has been to recruit additional providers, which obviously come at a cost. And I'm wondering, given those access challenges, I'm also looking at the clinical productivity that was submitted separate, not the premier work that you described in your presentation, but the work RVUs for clinical FTE. And many of those areas where you're adding providers have less than 25% productivity as measured by those national benchmarks. And so I guess my question to you is, why add providers rather than increase the productivity of existing providers to achieve the access goals?
Yeah, I mean, I think you have to do both, right? I think we have a really interesting mix. When I look at that clinical productivity, we've got somebody over the 90th percentile. We have some folks falling between the 50th and 75th, some between the 25th and 50th, but there are some that are below the 25th. You're absolutely right. I can tell you a couple areas, like the pediatric inpatient, that's a volumes issue, right? It's a really important service to have for our community. But I don't know that from a volume standpoint, we're ever going to be able to get sort of outside of that box. I think urology was another area where we were running under the 25%, and that was a contracted service for us. And we recognized the productivity was terrible and have had so many conversations to try to improve that and realized we weren't going to get there. So we have recruited our own, and our expectation is that it will be better. So I think each one has an interesting story, right? There's one area where I think the provider's still really, really new. So just starting to establish and build a practice. But we have opportunity. Every organization has opportunity. So I think we have to do both.
Yeah,
So
let me
what
just
are-
jump in there that many of those providers, their compensation is scaled based on their productivity. So we don't have anybody earning at or above the 50th percentile and producing, a lot lower. With the exception of somebody new. So when a provider comes in, we guarantee their salary while they build the practice, which I think we do for about 18 months. And then they go based on RVU as well as other quality and safety and engagement metrics.
Okay, appreciate that. So what benchmark goal have you set for the clinical providers?
We use a 50th percentile benchmark from a vendor called Coker Group. And so Coker Group looks at MGMA, they look at Sullivan Cotter, and they look at a group called AMGA, and then they develop a median using those three, and we use the 50th percentile.
Okay, so there are a fair amount that are currently at the 25th percentile or less. Is the expectation that they will be at the 50th percentile in 25? What assumption about productivity is in the 25 budget?
So again, we go area by area, and we actually go physician by physician and say, like, are you new? Are you established? Where are you at currently? And we make improvements. So like in urgent care, we have built in some improvement. That was one of the groups, I think, running below the 25th percentile. Again, in urology, we have built an improvement. We've got our own now. It's not a contracted service. So not for every area, but for some of the areas we have done that, and we have put those increases into 2025.
Okay.
Sorry,
a couple.
there's teeth in that. So if they don't produce, we adjust their compensation. If that happens multiple years, then we take a look at whether, their goals are aligned with ours as an organization.
Okay, thank you. A couple other questions about the income statement. It looked like there were very large reductions in fixed prospective payment. Just looking fiscal year 23, it was 21 million, 24 projected is 15 million, and for 25, it's 3.9 million. I'm wondering if you could just talk a little bit about that really large decline in fixed prospective payment.
So our budget submission assumes that we are not a part of OneCare on January 1st of 2025. So you see
Okay.
3 months worth of information, and then it would be 0.
Okay, and that would explain why the ACO dues are going from 800 to 170. Okay. And can you talk a little bit about that decision then?
It was the final year of this version of the ACO, right? So we very much look forward to, what comes next and evaluating the AHEAD model and all of that. But so for us, this final year of participation, it really just came down to a financial decision. So it just was not financially advantageous for us to be in.
When we looked
Okay.
at including that in the budget, the rate increase request would have risen to 12%, and we didn't think that that was appropriate.
Okay. And you have $1 million, it looks like, reserved. It's fiscal, so I'm wondering, it's still in the reserve pile there, but you're not participating. So where does that $1 million go?
So we'll have to wait for the claims run out to happen for calendar year 2024 before we can clear those reserves. It will take almost all of 2025, right? So we'll get an idea of whether those reserves can be released, come fall of next year.
Okay. And I guess the last question on the income statement would be the $37 million in other non-salary expense. Can you just remind me of what that is?
Yeah, I'll take a look at that. So it's a lot of contract services and other supplies that don't have an identified category here. Those are the big categories. So I don't have a crosswalk here in front of me, but those are the big ones.
Okay, is it possible just that's such a large amount of money? Is it possible just in follow-up to give it, not line item by line item, but just some smaller bucketed areas for us to understand what that would be really helpful.
Absolutely.
Let me just see if those are all of my questions. Oh, I guess just one other question about in terms of the nope, I think actually that was answered. Yep, I think I'm good. I'm going to turn it back over to Chair Foster or whoever's next. Thank you.
I don't have any questions myself at this time. Any other board members?
I can go ahead. I have just a couple, I think. Hi, everyone. Thanks for joining us. So my first question is in the narrative, and I think this is reproduced or very similar to what you've included on slide, I think it's slide 18 about the access. Could you just go over again how you came up with the percentages? Is that percentage of increased time, percentage of increased revenue, percentage of increased appointments? What is it a percentage of?
Yeah, Devin, do you want to take that one?
Sorry, remember Ledge, which item are you referring to?
It's your slide 18 or on page 4 of your narrative, you're talking about your new provider resources and budget to budget increase and access as a percentage. So for example, cardiology, fiscal year 24 budget to fiscal year 25 budget increase in access 30%. And if it'd be easier to follow up, that's fine.
It might be. I'm just see if I can pull up the narrative here and refresh my memory on that one.
Sure.
I know that the office visits are definitely in there. What I'm looking to Devin to see is, are the ancillary services included in there as well, or is it just the office visits?
That would have been a measure of just office visits.
Okay, so it's an increase in number of visits.
Yes.
Or is it money? It's not money, it's visits.
They're linked, right, by an underlying rate, of course.
Okay, yeah. All right, thank you. That question has been answered. Just what else I have here. I was just curious. So for the New England Collaborative Health Network, you talked about the 1.4 million in savings to community partners from that opportunity. And Stephanie just talked about the decision around OneCare. In looking at those two, did you look at how much in PMPMs your community partners would be losing from the withdrawal from OneCare? So did you look beyond your own financial calculation?
Absolutely. We spent the last year discussing it with the community partners. We met on a monthly basis. It was difficult to get the data, to be honest with you.
Yeah.
Some were willing to throw the number out, no problem. Others a little more guarded about it, and couldn't get it from OneCare either. So, but we knew it was substantial, and we knew it was going to have a financial impact on them. And so we talked with OneCare about it. We talked with each of the partners about it. They understood, and we're going to make it work.
Thanks. I think those are all my questions that weren't answered by other folks. So thank you very much.
Hey, this is Dave Merman. I just have a couple questions. The first one I think you addressed, which is you don't know the answer, which is what is Northwest Medical Center's relationship with Quorum?
No, we know that. So Quorum Health Resources used to be, it became QHR, became Ovation. So we have a strategic partnership with Ovation. What we don't know is how that showed up as our pricing. They've never billed for us. They've never done anything. So I'm not sure how the name and our data got blended, but we have a strategic partnership with Ovation Healthcare. They provide us with an incredible access to GPO, benchmarking data, consulting services. They're a valued and 46+ year partner.
Okay. I've seen that relationship, I think, in the NASHP data. When you look at health systems, for some reason, it puts you in the Quorum health system, but okay. One quick question from the narrative. There's a grant-funded respite program. Sounded like a really great program, 2 apartments that you're able to rent. Really, I mean, I think you all know that I'm an emergency physician, so these are things that like we interface with often, and this is like, I mean, it sounds like a really valuable resource to the community. I was just curious if one, where the grant came from, and 2, if there's any opportunities or plans for trying to figure out how to sustain that after a grant runs out.
Sure, very proud about that. I'll turn it over to Stephanie to answer those questions.
Yeah, it is a really great program, and it'll escape me now, so I can send you exactly, I don't want to get it wrong, exactly where the grant funds are coming from. It's going really well. It kind of goes back to Member Walsh's, some of his questions. Like, we have that program. We actually just started a food bag program using some grant money as well. And so I think in the narrative, one of the things I asked to be held harmless from was like increases in expenses where there was corresponding grant revenues. Because if there's a grant available out there and it would help our community and would help address those community needs, if NMC has to be the one to do it, right? Like, let's do it. Let's go get those grant funds and make that happen. We do think there's a year 2 grant opportunity, but in year 3, it would become, okay, Northwestern Medical Center, now you have 2 years worth of data. Let's run the numbers and say, how many people were we able to place there? What did that save in custodial care expenses here at the hospital? And so does that program pay for itself? And that would be how we keep it going.
Okay. That's great. I was excited to read about that. 2 more quick questions. I'm curious about your Medicare Advantage plans. Could you don't have to give it now too, if you could give it in follow-up, your dominant Medicare Advantage plans and maybe the top 5 plans or something by a percentage of your contractual mix. I think it'd just be helpful to understand who are the plans in Vermont. And
we can give you the top 5 for sure.
That'd be great. And the last question is around RAND pricing. I don't know if you've had an opportunity to look at RAND pricing. It's displayed in 2 different ways. One is a percent of Medicare and one is a standardized price. And when comparing hospitals that have different underlying Medicare reimbursements, the standardized price is really helpful. So you have the lowest standardized price for outpatient services in Vermont, and you have the 3rd lowest standardized price for inpatient services in Vermont, pretty close to the other 2 for the inpatient, a little bit below Copley for outpatient, and then Springfield's a bit above that. And I was just, I've asked hospitals what they think about this, but I'm curious what you think about these low RAND prices and how that impacts your ability to deliver care in your community.
Yeah, I mean, I think for us, it's a double-edged sword. Like, we're proud to have really low prices. And again, I think, I just heard in the last presentation where you were like, price versus charge versus reimbursement, and we all kind of use these terms differently, and I totally agree with you, and I love the idea of having like standard common language. But I think, what I'm charging and then what I'm getting reimbursed, or in this case, the prices, of course, they're linked, right? So to the extent that a large chunk of our business is, based on a percent of charge, if we're looking at the commercial side, then all of those things are linked. It's great to have kind of low prices, but at the same time, if they're too low, it makes it really hard to survive as an organization. So it's all about trying to find the sweet spot. And so I absolutely agree with Copley that it's like low's a good thing, but too low is a little bit dangerous. And so I don't know if I'm answering your question at all, but it's all connected, and I love the idea of being able to develop some common language and looking at it more together, because the data is pretty cool. I had a chance to dive into it a lot over the last couple of weeks.
Yeah, and I think like Copley made the point, it becomes relevant when you think about the rate increase request. So if somebody's getting $100 and you're giving them a 5% rate increase request, that generates obviously very different revenue than if someone's charging $10. And so when you're a low cost provider and you've not asked for a lot of rate increases, even though our rate increase is a little bit more than others, and still less than some too, it doesn't always translate into big dollars because we're starting from a low cost. And unfortunately, what we're not able to do because of the way insurance is structured in Vermont, I'd love it if Franklin and Grand Isle counties had insurance rates based on costs that they experienced here at Northwestern Medical Center. That'd be great. But as you know, the way insurance is structured in community rating, what our rate increase doesn't correlate to what Blue Cross, will charge Ben and Jerry's or Viatech or, the different companies in our area. It's based on what they experience across the state. So it makes it challenging. And again, this makes it challenging for you as well when we say, hey, we've got to control insurance costs for our community. Well, we're doing our part, but they're impacted, you could argue fairly or unfairly, that's not for me to say, by what goes on in the rest of the state. So, I think that is very complicated when you start to kind of wrap your head around it that way.
Yeah. Thanks for that perspective. Thanks.
Thank you. I'll turn to the healthcare advocate for questions or comments from them.
Yeah, thank you. Just a few. Thanks for the presentation. Appreciate it. And thanks for working with us on the Act 119 compliance. I think we have a lot to learn from each other. I mean, I think we come at it with a different perspective, but we want to listen to your perspective too, because we're not in the rooms waiting to talk to people. And so just wanted to briefly note that and highlight the work that Emma on our team did. I don't want to take credit for things that I didn't do. It was really her effort on our team. Just a question about, and maybe this reflects my desire for consensus, which I get teased about on our team for a little bit, which is fair. On the New England Collaborative Health Network, one concern that I have transparently is folks might, disagree about how costs are shared or how savings are shared. I'm just wondering if you feel like that's a reasonable concern to have, or if that's relatively well navigated already.
It's always a good discussion to have. We're different scale organizations. Each of us brings a different size and a different purchasing level. And so, where do you hold things flat across the board evenly, and where do you scale them based on your size and contribution? The collaborative exists and will survive based on one thing and one thing only, and that's mutual trust. So the way that we've initiated the collaborative is in a way that supports the highest level of trust. And so some things are scaled and some things are flat in terms of expenses and benefits. I will tell you, even if you flip the switch early on, there isn't going to be a significant amount of difference because generally speaking, we're all small hospitals. So, we're not dealing with David and Goliath here. Where we can say, you contributed this, and so this is your fair share back, we do that. And where it's more complicated to do that, we try to flatten things out. Did that answer your question?
Yeah, no, that's helpful. Thank you. One thing you talked about in the narrative, this is just kind of on a different line, was about the efficiency of the urgent care and how you wanted to scale that up and how you hope that would impact patient choice. I wonder if you could just talk about that a little bit more, because it's hard for me to understand how that would impact the choices that
we
patients
measure
make.
productivity in urgent care by patients per hour per provider. Right. So again, down to the individual provider level, how many patients are they seeing? So we know how many providers we should have. We're not where we need to be. You know, the industry average is around 5. I think that's, you know, factory medicine. I wouldn't support nor ask our team to be at 5. We're at, I think, just under 2. We're budgeting to be at 2. We really should be at 3. And that's reasonable, right? You go to a primary care office, you're seeing about every 20 minutes. And that's a reasonable. The problem is, you know, we've ratcheted down provider staffing to match what we think the market volume is. There are some variabilities in volume that we can predict. Monday's always going to be crazy. Tuesday's always going to be light. It's predictable. There are seasonality stretches that we can't predict. Why was the last 2 weeks really slow, and then the 2 weeks, you know, preceding that incredibly busy? Our mechanism to enforce some of that stuff is complicated. We've had a near 100% turnover in providers, simply because when we changed the productivity metric, the providers that were there didn't feel that, you know, seeing 2 or 3 patients an hour was reasonable. They felt, I think it was 1.7 was too much already. Well, we didn't agree with that, so we made that change. Unfortunately, there's only a limited amount that we can do, because I could say shut it down or bring it down from 2 providers or 3 providers on a day to 1 or 2, but that just means things could get backed up in the emergency department, which A, is expensive, B, gets in the way of care to people who really need emergency care, and just creates higher levels of dissatisfaction. So we are looking at our systems, our processes. What is it that we're doing in there that makes it take longer or inhibits getting the productivity to where it is? We are planning on bringing in Ovation as an example to do an operational analysis, who works with hundreds of hospitals across the country, so they could say, you do this process or you have this person do that process, and that's wrong. You should really do it this way. So we're making all those changes, along with you know, driving forward some cultural changes without doing it so hard and so fast that we throw out the baby with the bathwater, if you will.
Thank you. I appreciate that. And all my other questions were answered by asked by other board members. So thank you. Back to you, Chair Foster.
Great. I don't think there's any other questions for you all, and thank you for your thorough presentation today. Nice to see you all. We will take a break and adjourn until 2:30, and then we will come back with Brattleboro Memorial Hospital. Thank you, Mr. Wright, and everyone.
Our pleasure. Thank you very much.
Okay, we can go off the record, Michelle.
Okay, we're off the record.